Okay, let's talk about something we see all the time, a lump on the side of the face. For the patient, it's obviously a huge source of anxiety. For us, it's a diagnostic puzzle. So today, we're going to take a surgeon's eye view and really decode parotid tumors, from the everyday benign cases to the ones that keep us up at night. Here's how we'll break it down. We'll start with that initial presentation, the lump. Then, I'll introduce you to a fantastic mental shortcut, the Rule of 80. After that, we'll dive into the usual suspects, both benign and malignant. And we'll finish up by looking at a few conditions that can look like a tumor, but aren't.
All right, so it all begins when a patient walks into your clinic pointing to a new mass on their jawline. This is ground zero. And this is where our systematic approach, our diagnostic algorithm, really has to kick into high gear.
This is the big question, right? It's the one we have to answer. And while the patient is understandably worried, it's our job to cut through that fear with a clear, logical process. And that process starts with two things: anatomy and location. And here is our key anatomical landmark. You see a mass located just behind the angle of the mandible. That's the classic textbook spot. It immediately vaults a parotid gland tumor to the very top of your differential diagnosis. It's the most common way these things show up. So with a potentially long list of possibilities, it really helps to have a framework to guide your thinking. And in the world of parotid tumors, we have this incredibly useful tool called the Rule of 80. It's a simple mnemonic, but it gives us a powerful statistical shortcut to the most likely diagnosis.
Let's start here. Get this. A full 80% of all salivary gland tumors, they're found in the parotid. So if you're a head and neck surgeon, the vast majority of salivary gland tumors you see in your entire career are going to be right here.
Now, here's the really reassuring part of the rule. Of all those parotid tumors, 80% of them are benign. This is a crucial piece of information. It's something you can use to start counseling a worried patient from day one. The odds are overwhelmingly in their favor.
And we can drill down even further. Of that benign 80%, another 80% are just one specific type of tumor, the pleomorphic adenoma. So think about that. The moment a patient walks in, you already know, by a huge margin, what the most likely diagnosis is.
And that's the real beauty of this rule. It's probability in action. Now, of course, it's not a substitute for a full workup. Not at all. But it gives us such a powerful starting point. It helps us frame our thinking and lets us have a much more informed, data-driven talk with our patients right from the very beginning.
Okay, so the Rule of 80 points us straight at a benign pleomorphic adenoma. So let's take a closer look at this one and see how it stacks up against the other common players, both benign and malignant.
This table is a great little cheat sheet. On the benign side, you've got the two heavyweights, pleomorphic adenoma and Werthin's tumor. And on the malignant side, the two you absolutely have to know are mucoepidermoid carcinoma and adenoid cystic carcinoma. Just look at the key differences here: malignant potential and that all-important risk of nerve invasion.
This little clinical vignette, this is the absolute textbook presentation. A young patient, a slow-growing, painless mass, and, this is critical, an intact facial nerve. This just screams pleomorphic adenoma. So how do we bridge that clinical picture to the actual pathology? Well, under the microscope, pleomorphic adenoma has this classic biphasic appearance, a mix of different cell types. But here's the real kicker. While it's benign now, it has a 2 to 10% chance of transforming into a nasty malignancy down the road. And that's exactly why the standard of care isn't to watch it, it's to take it out with a superficial parotidectomy.
All right, next up is the second most common benign tumor, Werthin's. The classic patient for this one is totally different. Think an older male, often a smoker. And unlike a pleomorphic adenoma, Werthin's has this funny habit of being bilateral, so on both sides, or multicentric, meaning multiple spots. The good news, malignant transformation is incredibly rare.
Okay, so now we have to shift gears and talk about that other 20%, the cases that are malignant. Even though they're less common, we have to keep a high index of suspicion, especially if we see any red flags like rapid growth, pain, or any sign of facial nerve weakness.
When it comes to parotid cancer, these are the two big ones you need to master. On one hand, you have mucoepidermoid carcinoma. It's the most common, and luckily, it usually has the best prognosis of the malignant types. On the other hand, you have adenoid cystic carcinoma. It has the poorest prognosis, and that's largely because of one very specific, very nasty behavior.
and that behavior is called perineural invasion. This is an absolutely critical concept to understand. The tumor cells don't just spread out. They literally use the nerve sheaths as a highway to travel far away from the original tumor site. It's what makes these cancers so incredibly insidious. This perineural invasion is the hallmark of adenoid cystic carcinoma, and finding it is a major red flag. Clinically, it can show up as pain, which should never be ignored in a patient with a parotid mass. Surgically, it means a much higher risk of facial nerve involvement and post-op palsy. This changes everything about how you plan the surgery and how you counsel the patient.
And finally, let's not forget the mimics. Because not every swelling in the parotid gland is actually a tumor. Our differential has to be broad enough to include some important non-neoplastic conditions that can look very similar at first glance.
Okay, listen to this classic presentation. A patient comes in complaining of a super dry mouth, gritty, dry eyes, and has this diffuse, often bilateral swelling of her parotid glands. When you hear that combination of symptoms, your brain shouldn't be thinking of a focal tumor. It should be thinking of a systemic autoimmune process, like Sjogren's syndrome.
So Sjogren's is the classic autoimmune mimic. But we also have to keep infectious and inflammatory causes on our radar. HIV infection, for instance, can cause these bilateral lymphoepithelial cysts. And sarcoidosis, another inflammatory condition, can also cause bilateral swelling and, really importantly, can even lead to a facial nerve palsy without any tumor being present.
So after our history, our physical exam, our imaging, how do we actually make the final call? How do we get to a definitive diagnosis? Well, the answer is always in the tissue. A biopsy, whether it's a fine needle aspiration before surgery or the excisional biopsy itself, is absolutely mandatory. Because in the end, whether it's a benign pleomorphic adenoma or an aggressive adenoid cystic carcinoma, it's the pathologist's report that guides our hand in the OR and ultimately determines that patient's future.